third class for this course. The person who has his mic on, please turn it off. Well, okay, good. So, we'll be speaking today about two topics. So the first one will be finishing the ischemia, types of calcification, and amyloidosis, and the next portion will be speaking about the physiology of the heart. The first portion regarding the pathology, it's quite easy, it's not that difficult, but I have to say regarding the cardiovascular system, I need all of your focus. This topic is super important because without understanding this, it will be really difficult for you guys to understand most of the pathologies in the CVS. Today I'm going to be explaining only 3 pages from CVS. Why? Because these 3 pages are loaded with info. There is so much you have to master, and I will be asking you a lot of stuff from them after we finish the class. Also, this page of CVS, it will take almost like 2 hours or 1 hour on its own, and I would like, and we will do it tomorrow. So that will be for tomorrow. So for today, we'll be explaining pathology and CVS, and I want to start a quick poll with you right now, guys, and I want you to tell me, would you like me to do the difficult one or the easy one for the difficult topic first or the easy topic first? So please answer to the poll right now. Hard topic or the easy first? Okay, great. Okay, couple of difficult. Come on, guys. I just want to. I don't care. So let me choose hard. Oh, 6 votes says hard. Okay, so let's together at the same time. So okay, let's start with the hard one. We'll start with the CVS. Guys, I need all of your focus now. So CVS. First of all, we need to speak in general about the structure of the heart. We have 4 chambers, 2 atrium, 2 ventriculi, and we know that they pass blood from one chamber to one chamber and all of this stuff. Now let's go a little bit back. This is physiology, the function of the heart. We spoke about how the heart has 2 functions. The first function was pumping and the second function was hormonal. For today, forget about the hormonal function. We are going to speak about the heart as a pump. So this pump has does the following. So first of all, we have something called the stroke volume, contractility, blah, 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 a lot of stuff. But to make it simple for you, it's just a pump. So this pump, if you, for it to release blood from the left ventricle, and I will keep telling you guys today about the left ventricle a lot. So this is the left atrium and the left ventricle. The left ventricle, and this is the basically the aortic valve. The left ventricle walls are quite thick. Even when you look at them like in the morgue, you can see how thick they are. They are really thick. The reason is that they have a lot of work to do. They have to pump all of that blood out. And the ability of them to contract, we call it contractility. Okay, so this is the first thing you have to know. Contractility. Contractility is the ability for them to contract. So there is something called the stroke volume. So what does the stroke volume mean? Well, the stroke volume is how hard they contract. So contractility is their ability to contract, and the stroke volume is how much volume is contracted out of the heart during each pump. So if we speak about the stroke volume, they are affected by each other proportionally. So the stroke volume is affected by the contractility, afterload, and the preload. So let's try to understand what each of these mean. So the contractility, first of all, is how strong it contract into itself, like how strong this contract to the inside. The second thing is the preload. What does the word preload mean? It's how much blood is located inside of the chamber before it pumps. So it's how much blood is located inside of the chamber before it pumps. I will make it green here. And the last thing is the afterload. The afterload, how much there is pushing back from the systemic vascular resistance back to the heart. I know that a lot of you are looking at first aid and saying just a couple of words here, but this is much more difficult than it looks because they don't ask you the stuff like that. So there is pushing back. What leads to the pushing back? It's something called the systemic vascular resistance. A lot of the students don't really understand what systemic vascular resistance means. It is something like this. If you imagine that you have a hose, like in your garden, and you bring this hose and you bring and put your fingers on the hose, what will happen to the flow of water? Correct, the flow of water will be faster. The same, why? Because you increased the resistance. So that will let the fluid to be pushed forward. So let's imagine that this hose was closed from here, and then you pushed on it here, so you decreased the diameter. What will happen to the pressure inside of that tube? Correct, it will increase. So this is exactly what happens in our body. So when you have vasoconstriction of your vessels, that will increase your systemic vascular resistance. Now a common USMLE question, what portion of the microcirculation is responsible for the systemic vascular resistance? If anybody of you are thinking about the capillary, he's wrong. Actually, the thing that is responsible for the systemic vascular resistance is the arterioles, guys. So I want to show you something. There is something called the precapillary sphincter. Precapillary sphincter. If you take a look at the precapillary sphincter, it looks something like this. Yes. So take a look at this. Most of you have never heard of this, but here is how it looks like. So this is precapillary sphincter. It's just a sphincter that contracts. So here we have an arteriole, and it has like this precapillary sphincter on it, and then we have the capillaries here. So it's not in the capillaries, it's in the arterioles. So that regulates how much blood is going to the capillary. So if it contracts, less blood. If it dilates, more blood. So what contracts it, what dilates it? The hormones. Well, that's one thing. And the neurotransmitters, or your sympathetic nervous system contracts it. Your parasympathetic nervous system relaxes it. So it controls your systemic vascular resistance. By what? The arterioles. You have to know that it is the arterioles, the one that controls your systemic vascular resistance. And your systemic vascular resistance control your what? Correct, the afterload. And the preload is mainly mediated by the end diastolic volume. So what is end diastolic volume? Well, the heart has two phases, systole and diastole. During systole, the heart pushes the blood out, but during diastole, the blood is accumulating inside of the left ventricle. So if we do this picture that I keep drawing, left atrium, left ventricle, and aorta, during the diastole, what is contracting? Of course, it's not the ventricle, it's the diastole of the ventricle, so he's relaxing. But what happens is that actually blood starts passing from the left atrium to the left ventricle. And after the blood is pushed downward, towards the ending, the left atrium feels like he has a little bit of blood left, so he's like, so it contracts a little bit. So initially, it's just moving the blood passively, but eventually it has to contract a little bit to push the blood from the left atrium to the left ventricle. If you push the blood from the left atrium to the left ventricle, and that's it, that shuts. So now this one is shut, this one is shut. And this is isovolemic relaxation. At this point, isovolemic contraction starts. So at this point, what happened? All of these valves has closed. We have accumulated of blood here, and this guy contract. Well, the amount of blood inside of the heart at this moment, we call it the end diastolic volume. And it's associated with what? Correct, the preload. Good. So now, afterload, systemic vascular resistance, preload, and diastolic volume. I hope these two make sense, because we are going to build up from here. Please, guys, if someone does not make sense for him, write me. The preload one. Okay. Again, so the preload is the amount of the blood that is located in your left ventricle during the end of diastole, which is the end of the relaxation of the ventricle. So during diastole, the heart accommodates to more blood to take it from the atrium. So all of the blood goes here. That amount of the blood that is located inside of your left ventricle during full relaxation, we call it a preload. So let's imagine that your body is in a state of hypervolemia. You have a lot of fluid in your heart. Your preload will go up or down, right? Actually, let me do this. It will go up. Since the amount of the volume will go up, your preload will also go up. So it's proportionate to the what? To the amount of the volume inside of your body, the preload. Now we are going to explain every single one of them. So the stroke volume, they write, stroke volume is affected by the contractility. We explained that. Afterload, we explained that. And the preload, we also explained that. So there will be an increase in the stroke volume with the following. So contractility, what makes your heart pumps stronger? Anxiety. Why anxiety? Well, when you are really anxious, your sympathetic nervous system starts firing your fight or flight response. So what does that mean? Let's imagine that you are running away from the lion, and why the lion? Because he's scary, and your sympathetic nervous system will be shooting. That's what is the function of the sympathetic nervous system, to make you hyperarousal, to make you run away from the stress. So yeah, anxiety. So, what mediate this? Epinephrine, correct. So also exercise. All of these increase the contractility of your heart. So the heart is contracting harder, and that leads to more volume going out of the heart. So your stroke volume goes out. So by the way, you have to know, guys, stroke volume is how much blood going out of the heart per 1 beat. Okay? It's how much blood going out of your heart per 1 beat. You're like, well, why you say per 1 beat? Because there is a concept called cardiac output. It's different. So the stroke volume, it increases by increasing the contractility, also increases in case of a preload, like early in the pregnancy. You know, ladies who become pregnant, they have more blood inside of their body, which is like physiological. They are supposed to have that. And since they have more blood inside of their body, their heart has to, work more. They have more plasma in their body, so they're having more preload because there will be more blood going to the heart. They are in a state of hypervolemia. Yeah? And also, one more thing that increases your stroke volume, if you look here, if I want to push blood from the left ventricle to the outside, to the aorta, if I have so much resistance against it, the amount of the blood pushed outside of the ventricle will reduce. If you remember, like we took it in school, if you have like one arrow going here, one arrow going here, they cancel each other. So this arrow is resistance, and this arrow is how much volume is going out from the heart, okay? So if there is more systemic vascular resistance, which is mediated by the arterioles and especially the precapillary sphincter, the afterload will increase. If the afterload increases, you can think what will happen to your stroke volume. Correct, it will decrease. Excellent job, guys. So the next one. Okay, they write, a failing heart has decreased stroke volume. So if someone has heart failure, what is the main thing to check? No, it's not stroke volume, but the stroke volume is related to the thing we check. So a person with heart failure has a decrease in the stroke volume, obviously. Systolic and or diastolic dysfunction. So in heart failure, when we speak about it, I will tell you that we have two subtypes. We have systolic heart failure and diastolic heart failure. They are totally different pathogenesis of them, and totally different concepts. And we'll be speaking about these later. Okay, now let's speak a little bit about the contractility of the heart. Stroke volume, I hope it makes sense. Does it make sense? Sorry guys, I'm taking some time on this, but you will understand why, because You have to get this for the sake of explaining the next one. Do you guys understand it? Awesome. Nobody's saying no, so I can keep going. Okay, contractility. So for contractility, well, we said if you have higher contractility, your stroke volume will go up. Correct. So contractility and stroke volume increase with the following. Remember when we spoke about anxiety? And what was mediating anxiety? Epinephrine. Correct. So epinephrine is an example of catecholamines. Correct. Catecholamines comes from which amino acid? They love to ask this question, guys. Phenylalanine. Correct. So if you forget, guys, you have to go to biochem, metabolism chapter, and go down here. Little bit afterward. Yes, here it is. So if you take a look here, phenylalanine ends up to make you norepinephrine and epinephrine. They love to ask you about this and tell you which amino acid they come from. So it can be phenylalanine or tyrosine. And in the future, I will be explaining you this graph. It's super important. So let's go back to CVS. So the contractility, the patient will have the following. When it increases with catecholamine stimulation. Via which receptor? The beta receptor. So you're like, what is this beta receptor? For you that who already doing clinical medicine and forgot about this, we have alpha 1, alpha 2, beta 1, beta 2 receptors. These receptors are located in various tissues inside of your body. There is an easy way to remember which secondary messenger each one of these has. Just remember it with the mnemonic KISS. So when you see the catecholamines, you have to give them a kiss, but it's with a Q. So it's QISS. So the secondary messenger of the alpha 1 is a Q. This one is I, this one is S, this one is S. You have to know this. Okay, guys, let's go take a quick look here. The alpha 1 receptor are mostly located in the vessels. And guys, I want you to be a little bit interactive. Do they lead to vasoconstriction or vasodilatation? Excellent, vasoconstriction. What about beta 2? Beta 2, vasoconstriction or dilatation? Excellent. What about beta 1? Which organ are they located at? Beta 2, where they are located at? Yes, lungs, bronchi, correct. What about alpha 2? Where are they located at? Skeletal muscle and arterioles for beta 2, that's correct. What about alpha 2? Where else? Okay, guys. Excellent. The one who said CNS, excellent job. So these are inhibitory, and they actually does participate in inhibitory function on the CNS. So you must know this actually. Okay. So catecholamines stimulation via the beta 1 receptor, there will be an activation of the protein kinase A. The student will be like, what is this protein kinase A? I'm already confused. So I'm like, wait, let's go back to the graph. So it's a P1. So the secondary messenger is what? It's S. So you have to ease up, go back to pharmacology, move a little bit forward. And there is like a little scheme that you will have to memorize for each one of them. I know it sucks, but you have to do all of them. So here it's a GS receptor, yeah? So in this case, it's the GS, contractility, beta 1, because it's located on the heart. So the receptor will be bound to a beta 1 agonist, and that will lead to activation of the GS. Activation of the GS, which is the secondary messenger, will lead to activation of an enzyme called adenylate cyclase. So this adenylate cyclase is an enzyme that leads to ATP being converted to cyclic AMP. And this cyclic AMP will increase one other enzyme, which is called protein kinase A. And that protein kinase A will increase the calcium inside of the heart, and we will study in physiology soon that if you increase the calcium inside of your heart muscle, that increases your contractility. In the same time, the protein kinase A will lead to an inhibition of the light chain of the smooth muscles, which lead to vasodilatation. That's why beta-2 receptors lead to vasodilatation, guys, because it leads to inhibition of the myosin light chain kinase. By the way, guys, I just saw this question. I have a friend and he told me that he had his question on the exam. So I will ask it for you guys. Hopefully one of you will answer it. That would be cool. Can you tell me, please, if someone they mentioned for him someone with diabetes insipidus, okay? And after that, they told him, like, this guy in his circulation most likely, this patient will most likely have increase of which of the following substances? So, answers were, well, all of you are thinking like, yeah, it will be the osmolarity of the serum. But no. They ask him about this stuff. The answer were, like in case of diabetes insipidus, will the patient have a nephrogenic diabetes insipidus? Will the patient have increased cyclic AMP, increased ATP, increased adenylate cyclase? What is the answer? Look, guys, if you do not have the ADH, you do not have the ADH. What will happen to your you have the ADH, which is like the antidiuretic hormone in case of diabetes insipidus. The hormone exists, but the kidney receptor is not getting it. Okay? So there's exactly no receptors. The receptor will be secreted. So if the receptor is bad, the GS will be high or low. There is no info. The receptor is not being activated. Low. It will be low because the receptor is not being activated from the hormones. So the GS will be low because the receptor is not being activated. So if that will not be activated, GS will not be activated. Adenylate cyclase will be high or low? Low, of course. So if adenylate cyclase will be low, what will be high? ATP or cyclic AMP? ATP, obviously. So yeah, that's how you get the answer of this question. It's a really tricky question. You have to know every single step to be able to answer it, but he got it in the real exam. I have to say, when he first told me about it, it took me 5 minutes just to think about this, but it was really tricky. Well, anyway, let's go back to CVS. By the way, guys, do not over stress some equation on the exam. There is some equation that are made for the 250s and the 260s and the 270s, so yeah, keep that in mind. Okay, so here we have stimulation of the beta-1 receptors lead to activated protein kinase A. We just saw that. So that lead to an phosphorylation. Kinase, any word that has a kinase in it, kinase means something that put a phosphate on something, okay? So there will be a protein called phospholamine. We'll see it again, don't worry about it. So this phospholamine will get phosphorylated by what? By a kinase. Kinase always phosphorylate. And this phospholamine get phosphorylated, what will happen? Active calcium ATPase will lead to increased storage of the calcium in the sarcoplasmatic reticulum. Be like, what is sarcoplasmatic reticulum? You remember the endoplasmatic reticulum? When it is in the cardiomyocyte, the endoplasmatic reticulum, we call it sarcoplasmatic reticulum. It's exactly the same thing. So this phospholamine is the one, it's just like I imagine it like a channel that takes the calcium. If this is the cell, okay guys, and inside of the cell we have a nucleus, a lot of stuff, but we have also what? Rough endoplasmatic reticulum. This rough endoplasmatic reticulum has this phospholamine on it. And this phospholamine, what is its function? It's a calcium channel, okay? And when the catecholamines bind to which receptor? Beta-1 receptor. When they bind to the beta-1 receptors, secondary messenger of the which is GS, will be like, okay, GS, convert ATP to cyclic AMP for me. Oh, I have cyclic AMP. What should I do with it? Well, make a kinase. Remember, protein kinase A. That protein kinase A will go to the phospholamine, which is this channel, and will activate it. The activation of the phospholamine channel, which is a calcium channel, will take the calcium, and I always like to make calcium blue. You know why? Because it looks blue in histology. It will take calcium, where? To the inside of the sarcoplasmatic reticulum. So you will be like, what is the use of this? So we did all of this process. You see, it's quite a long process. Why would you take the calcium and put it in the sarcoplasmatic reticulum? Well, it's actually not because we like it, but it's because when we do that, we can have calcium-induced calcium release. Okay, guys? So when the time comes for the contraction, there will be a release of calcium from the endoplasmatic reticulum in a large amount that leads to a stronger contraction. Remember always that calcium contracts. So activated protein kinase A, and we spoke how it gets activated by the cyclic AMP, which comes after the adenylate cyclase has changed ATP to cyclic AMP. So the protein kinase A also lead to calcium channel phosphorylation, which increases calcium entry to what? To the cell itself. So the sarcoplasmatic reticulum, we spoke about how we have more like calcium stored in the sarcoplasmatic reticulum. But also we have here calcium channels, okay, on the cell itself. And these also will be phosphorylated, how? With a kinase. Which kinase? Protein kinase A. Who stimulated that? Cyclic AMP, which comes from what? ATP. With the help of what? Adenylate cyclase. Who activated the adenylate cyclase? The GS. Who activated the GS? The beta-1 receptor. Who activated the beta-1 receptor? Epinephrine. You guys need to be careful resuscitating all of this cascade. Do it 3-4 times and it becomes a second nature for you guys. So today when you are sitting in the bathroom, think about it. And yeah, just resuscitate it inside of your brain and it becomes a second nature for you. Okay. So activated protein kinase A. That will lead to more calcium channel phosphorylation. That increases the calcium entry. And when we have more calcium inside of the cell, remember, inside of the cytoplasm, that will lead to calcium-induced calcium release. Well, calcium-induced calcium release, where is the other calcium will be released from? From the storage. And where we did store the calcium? Remember? Correct, the sarcoplasmatic reticulum. With the help of whom? Phospholamine. And how phospholamine stored the calcium in the first place? With the help of protein kinase A. Again, protein kinase A is activated by the help of cyclic AMP, which is made by the help of adenylate cyclase, which convert ATP to cyclic AMP. And the adenylate cyclase itself is activated by the GS, which is a secondary messenger of the beta-1 receptor, which is activated by the catecholamines. Okay, guys. So there will be more intracellular calcium. You can imagine here there is a lot of calcium coming in that led to calcium-induced calcium release from where? From the sarcoplasmatic reticulum after all of the storage happened. Okay. So more intracellular calcium, decrease in the extracellular sodium. So you are like, wait a second, it does not make sense. Why there is decreased extracellular sodium? Well, it goes something like this. Normally there is this exchanger, okay guys? This exchanger, normally what he does, he takes sodium from the inside, put it to the outside, and he exchanges it with calcium. That's what the exchanger does normally. But when the catecholamines are being secreted and all of this process is happening, you have a plenty of calcium inside of the cell. You don't need more calcium. So the cell will be telling this channel, stop. I don't want any more to see the calcium. And when that happens, sorry, I have to mute this. When that happens, there will be more calcium inside of the cell or outside of the cell? Inside of the cell, yes, because you cannot release sodium outside anymore. Excellent job, guys. So there will be decrease in the extracellular sodium, extracellular, and that's due to decreased activity of the sodium-calcium exchanger. So it's important. And the next thing, which is as important, it is something called what? It is called a drug. It's called Digitalis. Does anybody know another name for Digitalis? Excellent, digoxin, glycosides, yes. So Digitalis, it blocks the sodium-potassium bond and can lead to increased intracellular sodium, okay? So when you block the sodium-potassium bond, you are like, well, sodium-potassium bond, I feel like I heard it before, where I have no idea, but I heard it before. So this sodium-potassium bond is a bond located on the cell. Well, this cell is already looking disgusting, so I will make a new one. So here is a new cell. Okay, that's a new cell. It has a nucleus inside, has sarcoplasmatic reticulum inside. So this is sarcoplasmatic reticulum. Okay, and this is what? Phospholamine. Good. So let's see what they write. Digitalis is a drug that inhibits the sodium-potassium bond. Where is the sodium-potassium bond? Is it here? No. The sodium-potassium bond is actually located here. Okay? And since it is a sodium-potassium bond, but it requires ATP. It means that it has to push against the gradient. Yes? So it normally should do what? Like it requires ATP, we said. So it has to push against the gradient. So it should take sodium from inside of the cell and put it outside of the cell. So that's the movement of sodium. Yeah? In the same time, it will take what to the inside of the cell? Well, sodium, potassium. So it will take potassium from the outside of the cell and put it where? Inside of the cell. Okay, so a drug called Digitalis come here and basically block it. So let's block it. This is Digitalis. He stopped its working. So now you will have a lot of sodium inside, yeah? And this sodium, when it accumulates, it will block what other channel we just spoke about. There was one more channel that did something similar. So now you have a plenty of sodium basically inside of the cell. Do you need more sodium? Not really. So you will inhibit the exact same exchanger we just spoke about, which is the sodium-calcium exchanger. So this sodium calcium exchanger, we inhibit it. And when it's inhibited, what you will have more inside of the cell? Correct. You will have more calcium inside of the cell. So if you have more calcium inside of the cell, because you don't need more sodium inside of the cell, that's why we blocked this guy. So you will get more calcium inside of the cell. If you have more calcium inside of the cell, what you can do with it? Well, you can do contraction. If you don't want to do contraction, you can do calcium-induced calcium release, which can lead to contraction. And what is this? Oh, that's the phospholamine, which when the protein kinase A worked on it, it led to what? Well, a lot of calcium went inside, if you remember, guys. And now it's time to do what? Release all of it. So when you release all of it in the same time, what happens? Contraction. Correct. So, okay. So I just read this. There was plenty to absorb from you guys. So let me read the whole thing again. And on your book, if you feel you don't understand something, make a note, contact me on a private later, and I will explain it to you. So contractility and stroke volume increase with catecholamines stimulation via the beta-1 receptor. Remember, stimulation of the beta-1 receptor lead to activation of the secondary receptor. Which one? GS. GS activate adenylate cyclase. Adenylate cyclase convert ATP to cyclic AMP. Cyclic AMP activates protein kinase A. Activated protein kinase A go to the phospholamine and it phosphorylated. Phosphorylated means we activated. Activation of the phospholamine lead to calcium ATPase, which is basically inside of the phospholamine, to storage more calcium where? In the sarcoplasmatic reticulum. activated protein kinase A lead to calcium channel phosphorylation. So calcium channel phosphorylation, where are these calcium channels located? Make a note about it. They are located on the cell wall of the cell, not the sarcoplasmatic reticulum. Don't confuse it. These ones, these are located on the cell wall. So there will be more calcium entry, and that will lead to calcium-induced calcium release. Okay, so calcium-induced calcium release. That will lead to contraction. So this process led to more calcium inside of the cell, less extracellular sodium. Why? Because of less activity of the sodium-calcium exchanger. We don't need it to work anymore. So the final thing was about a drug called Digitalis, which we actually used to increase contractility or decrease contractility. Write me, please. Increase contractility, correct. So we use it in heart failure, for example. Excellent, in heart failure, yes. So we, but by the way, it does not improve the mortality. We use it only for the symptoms, okay? Keep that in mind. And it works by increasing the contractility. Why? Because it increases the intracellular calcium. Good. So contractility and the stroke volume decreases with the following. Remember all of that cascade? Now we'll take stuff that blocks it. So the first one, beta 1 activation led to increased contractility. So beta 1 blocker will lead to decreased contractility. Why? Because of decreased cyclic AMP. Why? Because the beta 1 receptor is not able to activate the GS anymore, so no adenylate cyclase anymore, so less cyclic AMP. But what will be elevated if you give a beta 1 blocker? Will it be cyclic AMP? Will it be ATP? Will it be adenylate cyclase? What will be increased? Excellent. The one that will be increased will be ATP. Someone just joined. Okay. So the next one is heart failure with systolic dysfunction. So heart failure with systolic dysfunction, it goes something like this. If someone has heart failure, his heart is not contracting. That's the main idea. But here they write systolic dysfunction. Well, that means in diastolic dysfunction, the contractility is normal. Well, kind of yes, but why? Because in case of diastolic dysfunction is a problem with relaxation, but systolic is a problem with contraction. So in heart failure with systolic dysfunction is a problem with contraction, so the contractility is decreased. You're like, okay, these two are fair, but how come acidosis can decrease your contractility? Well, it's acidosis, it's not related. Well, guys, imagine this. What does it mean when we say someone has acidosis? What actually exists in his blood? It's a lot of hydrogen, basically, a lot of protons. Protons are hydrogen, is the same thing, synonym. So a lot of hydrogen there, yeah? Maybe you remember that the structure of the enzymes in our body is quite big, and it's made of what? What are enzymes made out from? Well, 99% of them are made out of proteins. There is only like a couple we'll speak about that are made of RNA, but otherwise all of them are proteins. Since all of them are proteins, proteins are made of what? Amino acids. Amino what? Acids. Oh, okay. So amino acids has which structure? Well, it has a lot of things, but maybe you remember inside of an amino acid, you are not required to know the structure for the USMLE, but inside of the amino acid, it had like arms, like one arm had the NH on it, yeah, NH4. And since the arm has H's on it, if there is a lot of H's around, well, can that play with the amino acids and denaturate them and make them dysfunctional? Absolutely. So you mean that the kinases and the protein kinase A will not be functional anymore, and that will lead to decrease in the contractility? Exactly. So increase in acidosis inside of your body will denaturate your proteins. That will lead to decreased contractility. I hope it makes sense. Okay. The next one is hypoxia and hypercapnia. So hypoxia and hypercapnia. The hypoxia, why? If the heart is not able to breathe anymore, well, he needs a lot of ATP to move the stuff around. Calcium ATPase, it requires ATP. Well, A lot of ATP was required for the pumps, all of this stuff. So you need a lot of ATP to do this process. Without ATP, it's not doable, you know? Even to create the cyclic AMP, remember the cyclic AMP, guys? Which has been made from ATP actually with the adenylate cyclase. So if you don't have ATP in cases of hypoxia, why you don't have ATP in cases of hypoxia and hypercapnia? Because you remember the electron transport chain, it will not be functional. So no functional electron transport chain, no ATP made, no ATP made, no contractility. Can someone tell me where is the electron transport chain located? Okay, excellent, 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 guys. Good job. Even if you don't have the time to write, like the fact that most of you get it correct is awesome. So the last thing here is the non-dihydropyridine calcium channel blocker. You're like, what? Non-dihydropyridine calcium channel blocker? Yes. So you have two types of calcium channel blocker. You have the dihydropyridine calcium channel blocker and the non-dihydropyridine calcium channel blocker. The main difference between them is which organ they work at. Make a note. Non-dihydropyridine calcium channel blocker acts on the heart. How do they act? Exactly like beta blockers. Well, not exactly, but I mean they decrease the contractility. But which channels do they work at? The calcium channels. So the question comes, well, what about the dihydropyridine calcium channel blocker? Where do they work at? The vessels. They don't work at the heart, guys. Let me show you this actually. It's quite interesting. So in case of the non-dihydropyridine calcium channel blocker, I just want you to know examples of them. So there is this viramabile and diltiazem. Okay, guys? Remember these two examples. And yeah, so they basically inhibit the calcium channels and they prevent the process of contraction from happening inside of the heart because less calcium will be there. Okay, good. Well, guys, I have a question. Can ethanol, like alcohol, lead to decreased contractility? Just take a random guess. Yes. Well, there is many mechanisms. Actually, ethanol itself can burn your heart and literally give you dilated cardiomyopathy. But also, ethanol, really interesting fact, it can also block your calcium channel directly. Yeah, that's cool. Oh, acidosis? Well, it's possible, but yeah, I meant even on a smaller doses, but daily smaller doses on the long term. So, okay. So I hope the process of stroke volume and contractility made sense so far. Now it becomes a little bit easier. I have to say that was the most difficult topic for this page, the contractility thing. So preload. A preload is approximated by the ventricular and diastolic volume. You remember that? We just spoke about it. It's the amount of the blood at the end of diastole, which is the period where all of the blood inside of the heart was accumulated. It depends on the venous tone and the circulating blood volume. So we said it depends on the circulating blood volume. If you have the state of hypervolemia, you will have what will happen to your preload? In case of hypervolemia, your preload will go up. What about venous tone? Venous tone is actually important. Take a look, guys. So in case of venous tone, it goes something like this. So if this is your heart, chambers. So this is superior vena cava, inferior vena cava. And now I'm going to ask you a tricky question, guys. I hope you will not be tricked, but we will see. When we give nitroglycerin to someone, nitroglycerin decreases the angina of the heart. Is it because A, decrease in preload, low decrease in the preload, B, dilatation of the coronary artery? Let's see. Oh, awesome. All of you guys knew it. Well, that was impressive. Well, even in your world, I was watching the other day, 50% of the student got it incorrect. They choose dilatation of the coronary artery. It's incorrect. The correct one is what you choose, guys. When we have venodilatation, because of the use of nitroglycerin, and you have to know exactly how nitroglycerin does that. So nitroglycerin, actually, like it's a sublingual pill, which means you put it under your tongue. And when you do that, there will be release of a lot. It will go to your smooth muscles, okay? And near your smooth muscles, it will go to a cell near it, like inside of the vessels, called what? Inside of the vessels, it will be the endothelial cells. So it will go there and speak with something called arginine. Do you remember what is arginine? It's an amino acid. So it will convert arginine to nitric oxide. Nitric oxide will lead to vasodilatation. The vasodilatation will enlarge the vessel. Enlarging of the vessel will take more blood back from the heart to the venous system. So there will be pooling of the blood inside of the venous system. That decreases the preload. Does it make sense? Increased nitric oxide release. Does it make sense, guys? This how does nitroglyceride work? Good. So one more important thing about nitroglyceride, they write here something really important regarding the coronary arteries. It's not related directly to the coronary artery, and its function on them is minor, so it's irrelevant. Okay, so we decrease the preload. What is the big of a deal? Well, if you decrease the preload, the contractility of the heart does not have to work as hard, you know, because you have less volume, so the oxygen consumption of the myocardium will be less. If you have less oxygen consumption from your heart, that will improve your angina. And that's how nitroglycerin work and all vasodilators. Okay, the afterload. So the afterload is approximated by the MAP, which is the mean arterial pressure. And that I don't want you guys to worry too much about it now, because we will learn in the next page how to calculate it. But I want you to know that it's basically like the blood pressure, okay? So afterload is approximated by the blood pressure. Increased wall tension by the Laplace law means increase in the pressure, which increases the afterload. So students be like, what the hell is this sentence? What is Laplace law? Laplace law says something like this. It says, if you have a vessel and you decrease its diameter, the resistance inside of it goes up, okay? So if you decrease the diameter, if the diameter goes down, the resistance inside of the vessel goes up. If you forget about it, just remember about this water hose in the garden. When you push on it, you decrease the diameter, the resistance goes up. That's Laplace law. So increasing wall tension per Laplace law lead to increased pressure, which increases the afterload. Okay, so left ventricle compensate for the increased afterload by thickening. Do you remember the process of hypertrophy we spoke about? Here it comes. In order to decrease the wall stress. Well, important thing, I hope my student know it. In case of hypertrophy of the left ventricle, can the left ventricle undergo the process of hyperplasia? Why? Why no? Why he can? Excellent, he's in a G0 phase. He's a stable tissue. What other stable tissue do we have in our body? Neurons, CNS, skeletal muscle. Okay, good. So the CNS, skeletal muscle, and cardiomyocyte. Excellent job, guys. So back here. So we have the afterload. We have arterial. Oh yeah, sorry. They're right. Left ventricular compensate for the increased afterload by thickening, leading to hypertrophy in order to decrease the wall stress. Keep in mind, if you reach one area of hypertrophy, it will be too much stress for the heart. There will be cell injury. Why? Because there is not enough oxygen from the coronary artery to supply that really thick myocardium. So the tissue will just die. So in case of the afterload here, it also have some pharmacological relationship. If you use arterial vasodilator, not venous, nitroglycerin works in vein, hydralazine works in arteries. You must know this. Nitroglycerin, veins, hydralazine, arteries. So hydralazine, it's arterial vasodilator, and it decreases the afterload. Okay. Also, ACE inhibitors, which work on the RAS system, and ARBs decrease both the preload and the afterload. Really quick, I will not take a lot of time on this because we will speak about it maybe 20 times. So we have something called the RAS system. It's renin, which is secreted like from the kidney. Read the secretion of angiotensin 1, which is secreted from the liver. It's angiotensinogen released from the liver, then it gets cleaved into angiotensin 1. That becomes angiotensin 2. In which organ, guys? Where does angiotensin 1 becomes angiotensin 2? Yes, by the angiotensin converting enzyme. The lung, excellent. They keep asking about this one. And in the lung, which enzyme does that? The ACE inhibitor, the angiotensin converting enzyme. Well, that's the 260 question. Which cell in the lung contains the angiotensin converting enzyme? That's a tricky one. Well, actually, it will be the endothelial cells of the lung. Ooh, someone actually knew it. Wow, that's awesome. Good. So ACE inhibitor and ARBs decrease both the preload and the afterload. Why? Because you have less angiotensin 2, less blood pressure. Also, you have less angiotensin 2, you have less aldosterone. If you have less aldosterone, you have less sodium in your circulation. Less sodium, less water. Less water, less volume. Less volume, less preload. So it's just if you understand one, you can follow all of the others with it. It's just the main thing is to understand it the first time, and then anything after it becomes easier. So in case of chronic hypertension, there is increase in the MAP. So that leads to left ventricular hypertrophy. Which heart sound will be heard in case of left ventricular hypertrophy? Okay, good, S4, it's S4. So the last thing before the break, myocardial oxygen demand. So the myocardial oxygen demand increases by the following. The first one, contractility. So when someone has running from the lion, his contractility is up because his catecholamines are up. So there is a lot of oxygen demand. That's why we use beta blocker, guys. Someone has heart failure. Why do you give him beta blocker? Well, that decreases his contractility. Less contractility, it means less oxygen consumption. Less oxygen consumption, that decreases the angina, and that also decreases the ischemia and the hypoxia of the cardiac tissue. The next thing is increase in the afterload, also increase the myocardium work, which increase the myocardial oxygen demand because the heart have to push harder to push against that increased preload. So it's proportional to the arterial pressure. So the highest the arterial pressure, the higher the afterload. And do you remember which vessel is the mainly responsible for the afterload? Is it the aorta? Is it the capillaries? Is it the arterioles, the afterload? Yes, the arterioles, exactly. So the arterioles, do you remember what exactly inside of the arterioles is responsible for this? The precapillary sphincter, excellent. Good. So we have also the myocardial oxygen demand increases if you have high heart rate. So what gives you high heart rate? Well, catecholamines. Catecholamines comes from which amino acid? Phenylalanine, correct. So, finally, increased diameter of the wall can lead to increased wall tension. If there is more wall tension, there will be more oxygen demand. More oxygen demand, that means higher risk of hypoxia. Why would the diameter of the ventricle increase? Well, for example, the ventricle will want to compensate for an increased volume inside of the left ventricle, for example. Why would that be? Well, in case of aortic regurg, it can happen. Pregnancy, it can happen. Hyperaldosteronism cannot be happen. We'll say why later. It's because the aldosterone sparing mechanism that is really interesting. We will speak about it later. Anyway, So the wall tension follows the Laplace law. I hope you remember what that means. It means when you increase the pressure on the wall of something, the resistance inside of it increase. So let's take a look. Wall tension is equal to the pressure multiplied by the radius. So that means if you increase the radius, like in cases of dilated cardiomyopathy, the wall tension will go up. If the wall tension will go up, the oxygen consumption will increase. That will increase your risk of getting heart failure because the heart will be more hypoxic. If you increase the pressure on the walls inside of the heart, like in cases of you have more fluid inside of your left ventricle, like in cases of increased preload, the wall tension will go up. If the wall tension goes up, your myocardial oxygen demand will also go up, which can lead to hypoxia. Finally, the wall stress will lead to a pressure multiplied by the radius divided by 2 multiplied by the wall thickness. So what is that? If you have more wall stress, you will have more myocardial oxygen demand. So the pressure and the radius, we already know these two. But what about 2 times the wall thickness? So if you have more wall thickness, initially you will need more oxygen, guys. But if it enlarges so much, what will happen to the amount of the oxygen demand? It will be so high that it will not be met. So if it will not be met, please be careful. This is tension, this is stress. These are different, okay? So if it will not be met, what will happen to the myocardial tissue? It will die. And if it die, is cardiac injury reversible? Yep, ischemia. Is cardiac injury reversible? Okay, well, that's in the first period, but let's say that it occurred, exactly, depends. So let's say that they only discovered about this ischemia like, I don't know, 2 weeks later. Irreversible becomes. So how do you differentiate between reversible cell injury and irreversible? Which one has the cell membrane damage and which one has the blobbing and the swelling? Swelling, that's reversible. Enzymes, that's irreversible. Good. The tearing, it's irreversible. The swelling is reversible. Excellent job, guys. Now we deserve 10 minutes break. Actually, that was one of the most difficult pages in the book. Really good job. The physiology of the heart is difficult. The pathology is super easy. So if we go through the physiology of the heart, most of the book will be a piece of cake. So just hang on there and all will be good. For now, I am going to start the time for 10 minutes, a break, and we will be back. Come back. Okay, guys, welcome back. So let me just check. I unmuted myself. You can hear me, guys. And okay, so the next page, it's all about calculations. So first of all, we have something called the stroke volume. So when you go to check someone's blood pressure, you put this blood pressure cuff, you check, and you see that his blood pressure is 120/80. So I want you to know a couple of stuff before we read the page. First of all, you checked the blood pressure and it was 120/80. What does that mean? It means that the pressure inside of your, well, you actually check the brachial artery pressure, but it coordinates and it relates to the aorta pressure. So 120 is the blood pressure inside of your aorta during systole. And the 80 is your blood pressure inside of your aorta during diastole. Okay. So the main coordinator for the systolic blood pressure is the contractility of the heart, which is also mediated by the contractility mediates what? Stroke volume. Yes, so contractility, stroke volume, systole, 120. The diastole is mainly controlled by the afterload, okay? And the afterload is mainly controlled by the systemic vascular resistance. And that was controlled by which portion of the capillaries? The arterioles. I hope it makes sense. And the arterioles, the most important portion in them, the precapillary sphincter. I know that my writing is really bad, but guys, you just need to get the idea. Okay, so when we say the stroke volume of something, it means the following. Oh, just a second. It means the following. The stroke volume is the end diastolic pressure minus end diastolic volume minus the end systolic volume. Why did I speak about blood pressure when we are currently not speaking about the blood pressure? We are speaking about volume. We are speaking about the stroke volume. So because among the years and among each person I teach, they're always the same exact problem with the student that want to understand two concepts. The first concept is pulse pressure, and the second concept is stroke volume. They are totally different. They look different. Everything of them is different except the formula. So the formula looks kind of similar, and that's why the student confuse it. So when we say the pulse pressure is the difference between your systolic blood pressure minus your diastolic blood pressure. While if we speak about the volume, it's not related to the pressure at all. It's volume. So there should be volume. So it's end diastolic volume minus end systolic volume. Guys, think with me here. Which one would be higher, the end diastolic volume or the end systolic volume? Yes, this lecture is fully recorded, and here it is. Say hi for the camera. So which one is higher, the end diastolic volume or the end systolic volume? Excellent job. The end diastolic volume is much more higher. Why? Because it's the amount of the blood that was accumulated during the relaxation of the heart. So it's the highest amount that the heart could accommodate for, actually. Okay, good job. So if you minus this from how much blood stayed in the heart after the contraction, it tells you how much blood went outside of the heart. So we say that's the left ventricle, and before the contraction it has this. After this, and I will represent in diastolic volume in blue. So it had this in diastolic volume, blue. Now it tells you that after the contraction, I will make it in yellow, it only has this. Okay, so you put end diastolic volume, which is blue, minus end systolic volume, which is yellow. That would tell you about what? That will tell you about this amount, the red amount. This red amount is the amount of blood that got stroked out from the heart during that systole. I hope it makes sense. So the stroke volume is equal to the end diastolic volume minus the end systolic volume. That's the stroke volume. And yeah, I hope it makes sense. It's not that difficult of a concept. Now the ejection fraction, that's really important, and you need to be really careful with it because it helps you with the pathologies. So you remember the stroke volume we just spoke about, which was this guy? This amount of how much blood went outside of the heart during the one beat. That was the stroke volume. Now the ejection fraction is related to the stroke volume, and it's just mathematics. If you increase the stroke volume, what happens to the ejection fraction? It increases. If you decrease the end diastolic volume, what will happen to the ejection fraction? If you decrease the end diastolic volume, excellent, it will increase, just mathematics. So stroke volume is also calculated as follows, and here we have the end diastolic volume, still the same thing. So it's the amount of the blood that went outside of the heart during that one beat divided by all of the amount of the blood that the heart can fit during its maximal capacity during the end of the diastole. Okay, we call that the ejection fraction. Why ejection fraction is important? Well, see guys, all of these volumes that are kind of difficult to calculate, But the ejection fraction, actually, you can easily calculate it. How come? Well, maybe you heard about the method echocardiography. And this echocardiography will help you to know exactly how much blood is inside of the heart, how much blood got ejected outside of the heart during that frame of a second, and that will help you to determine how much is the ejection fraction. Does anybody here know how much is a normal ejection fraction? Excellent, 55 or more. Some resources say 60. Good. So ejection fraction is an index of ventricular contractility. So it will be decreased in case of systolic heart failure. So ejection fraction will be low in systolic heart failure, but in diastolic heart failure, it will be normal. Remember what I told you? I told you that systolic heart failure is a problem with contractility. Diastolic heart failure is a problem with relaxation. If someone has diastolic heart failure, he has no problem in contractility. Contractility is directly proportional to the ejection fraction. So the ejection fraction will not be touched. But the systolic heart failure, so contractility is directly proportional to ejection fraction. So if someone has high contractility, he has high ejection fraction. If he has heart failure and low contractility, he has low ejection fraction. But in diastolic heart failure, that's for relaxation. It's not associated with contractility, thus it will not affect the ejection fraction. Okay, so and you can check it using an echocardiography. You also can use it, can check it using really invasive procedure, but we don't really do them. But I will explain them for you later. So the next thing is cardiac output. It's how much blood is coming out from the heart during 1 minute. Okay? So again, it's how much blood going outside of your heart during 1 minute. So that's what? Stroke volume. It's how much blood was going out of your heart during one beat. Okay? So that was during one beat. If you want to check how much blood is going out from your heart during 1 minute, you multiply that by how many beats your heart beats per minute. So if you do this, you get how much blood is going out of your heart during 1 minute, because the heart rate is calculated per minute. Okay, there is another way to calculate the cardiac output, and it's called Fick principle. In reality, in real life, you will never do it. On the exam, you will always do it. So the Fick principles go something like this. The cardiac output is calculated as follows. Rate of O2 consumption, and it's different from tissue to tissue, and they will tell you that, don't worry about it. But what they will give you in a really tricky way will be the arterial O2 content and the venous O2 content. Look guys, I want you to be really careful with these guys. They tend to be tricky. I will give you how they give the trick. If they tell you that the patient pulmonary artery O2 content was 20, and the patient pulmonary vein content was 30. So pulmonary artery 20, pulmonary vein again. So let me just write it down to make it. So pulmonary artery O2 concentration and pulmonary vein O2 concentration. So if I tell you that the pulmonary artery had 15 and the pulmonary vein had 40, and then I give you this formula, and I tell you that the rate of the consumption, I don't know, let's just make it easy, let's make it 5. Rate of the consumption is 5. So you will want to plug it to the formula, you know? So you want to plug it to the formula. Rate of consumption is 5 divided by the arterial minus the venous. So this one is the pulmonary artery, this is the pulmonary vein. But guys, they don't ask about this. It's a different way. The fix is really should be like how much in the arterial content does not include the pulmonary trunk, because the pulmonary trunk has venous O2 actually, and the pulmonary veins have arterial O2 actually. So it's like the oxygenated and the deoxygenated type of trick, so be careful. So in reality, the calculation will be 5 divided by 40 minus 15. That will be 5 divided by 25. That will be 1/5. Okay? 1/5 will be your cardiac output. Just like an example. It's not like your cardiac output cannot be 1/5. So, okay. So cardiac output, you can calculate it in two mechanisms. They can trick you by asking you the rate of the O2 consumption and giving you the heart rate, the stroke volume, which will help you get the cardiac output. And then from the cardiac output, they will tell you the thing about the pulmonary trunk and the pulmonary vein I just told you. That will help you get the rate of the O2 consumption. And from there, like you had to calculate this to get cardiac output, put it down, put it here, take the knowledge I just gave you and plug all of this to what? To the rate of the O2 consumption. I hope it makes sense. So in early stages of exercise, the cardiac output is maintained by the increased heart rate and the stroke volume. So what does that mean? Let's imagine you are running. So you run. Your cardiac output will be maintained and it will be high. Everything will be good. How? Your heart rate is higher with the power of the catecholamines. And your stroke volume will also go up because your contraction is going harder, yes? But after some times, your cardiac output will be maintained by increased heart rate only. Why? The stroke volume will plateau. Why? Well, you can stroke your heart to, I'm exercising. I'm now stroking only 40 milliliters per second, for example. Okay, let's exercise harder. Now I get 50 milliliters per second. More. There will be a point that the heart will tell you, enough. I cannot do it anymore. So it will be increasing, then it plateaus. Okay? In contrast, if we speak about the heart rate, your heart rate can go up to 200. Actually, does anybody here know how to calculate the maximal heart rate of a human being? Okay, so to calculate the maximal heart rate for a human being, it's easy. You do 220 minus the age of the person. So let's say a person is age 40. 220 minus 40, so his heart rate will be 180. That's the maximal heart rate he can reach, that his heart can reach. Should you reach that? Well, people in the CrossFit love to do it. I don't like too much, but yeah. So it's help you burn a lot of fat much more faster because your aerobic glycolysis will be like functioning extra. Okay. So the diastolic is shortened with an increased heart rate. Yeah, you can imagine if your heart rate is happening more often, so contraction, more contraction, the diastoles becomes shorter. That happens in cases of ventricular tachycardia, which decreases the time of the left ventricle to be able to fill from the atria. So that that leads to decreased stroke volume and decreased cardiac output. Does anybody know when the coronary artery get their blood? Systole or diastole? Diastole, yeah. Okay, so we have the next thing is called pulse pressure. So pulse pressure is the thing that I told you to need to be careful about, not to make a mistake with a stroke volume. Totally different. This is volumes, this is the pressures. So here we have, if you get like this 120 over 80, if someone has a blood pressure of 120 over 80, his pulse pressure will be 40, okay? Because it's just systolic minus diastolic. I want you to know a couple of stuff about this. The first thing I want you to appreciate that it's highly associated with person that has this aortic regurgitation, okay? You must know this. And now we'll speak about other conditions that also will be messed up. So the pulse pressure is directly proportional to the stroke volume. Why? Because the higher your stroke volume, your systolic blood pressure will go up. That will increase the distance between the systolic and the diastolic blood pressure, which will increase the pulse pressure. And it's inversely proportional to the arterial compliance. Because the highest your arterial compliance is, the lowest your diastolic blood pressure will be. The lowest diastolic blood pressure you will have, the highest pulse pressure you will have. So the increase in the pulse pressure and the decrease in the pulse pressure. The increase in the pulse pressure can be in cases of hyperthyroidism, aortic regurgitation, and aortic stiffening. So why hyperthyroidism, guys? It leads to something called it leads to the following. So when in hyperthyroidism, we have the T3, T4 hormones, yeah? These go and overstimulate the beta-1 receptors inside of your heart. That will make your heart contracts extra. If your heart contracts extra, your systolic blood pressure will go up. So when it goes up, your pulse pressure will be wider, yeah? In case of aortic regurgitation, your stroke volume, you are stroking the blood out, excellent, but your diastolic blood pressure will be lower. Why? Because you are stroking it out, but then it comes back really quick, you know, so you are not stroking that good, basically. In aortic stiffening, what will happen exactly? Well, this one is tricky, so guys, be careful with it. In aortic stiffening, they speak about the aorta itself, not the valve, okay? Like the vessel is stiffed. And that's in case of systolic hypertension in elderly. While if we speak about the aortic stenosis, it's completely opposite to aortic regurg. So there will be decrease in the pulse pressure. Obstructive sleep apnea. When you read this word, obstructive sleep apnea, I'm not taking a lot of time on this because for each pathology, we'll have almost a whole lecture about it. In case of obstructive sleep apnea, this is a pathology highly due to obesity. Obese persons who have BMI more than 30 can have obstructive sleep apnea, which increases their sympathetic tone, and they can have an increase in the blood pressure. Okay. Also, anemia can lead to increased cardiac output, heart failure, and exercise. But the good thing about your exercise, that yes, it increases your systolic blood pressure. Yes, it decreases your diastolic blood pressure, increases pulse pressure. But overall, in the longer term, exercise decreases your blood pressure. And that's super important to advise someone with hypertension. By the way, guys, be careful. If they give you a question about someone with hypertension, and they tell you what is the first thing to give him, and you have like thiazide, ACE inhibitor, exercise, calcium channel blocker, the exercise is the correct one. Okay, so decrease in the pulse pressure will be in cases of aortic stenosis and also in case of cardiogenic shock. Okay, so less pulse pressure will be in aortic stenosis and in cases of cardiogenic shock. How come? Well, in cardiogenic shock, what will happen to your systolic blood pressure? It will drop. That will decrease the area between these two. What about your aortic stenosis? What will happen to your diastolic blood pressure? It will go up. So it will decrease the gap between these two. Cardiac tamponade. Same idea, decrease contractility of your heart. Advanced heart failure, decrease contractility. Okay. So the next one is the mean arterial pressure, which is the MAP. So the cardiac output, now we have to know exactly what it means. So mean arterial pressure, I just told you to remember that it's related to the blood pressure. So now you have to know exactly what it means. It is the cardiac output, and you remember the cardiac output, you remember how do we deal with it, how to calculate it? It's the stroke volume multiplied by how many beats per minute. So it's how much blood got outside of the heart during 1 minute multiplied by the total peripheral resistance. Total peripheral resistance is proportionally associated with the systemic vascular resistance, and you can actually use it interchangeably, which is highly related with the arterioles. Yes, it's the arterioles. If someone asks you, the mean arterial pressure is related to which portion? You have to tell him the arterioles. So, man, at resting heart rate, you can calculate it as follows. So there is two ways, but basically you get the blood pressure of the person, you get 2/3 of the diastolic blood pressure, and you plus it to 1/3 of the systolic blood pressure. Easier way to do it is the diastolic blood pressure plus 1/3 of the pulse pressure. Pulse pressure was the diastolic minus the systolic. By the way, guys, if you don't know all of these formula, it's okay. Anyway, one day before your exam, you will go to the rapid review section. There is this. Yeah, see, 1 page, 2 pages. You have to memorize every single one of these formulas. You will keep rewriting them so many times. It's all of the formulas you have to memorize in the book. From the loading dose and maintenance dose to pharmacology, until we speak about the renal blood flow. They are all here. So these all of the formulas you need for your exam. Anything else you don't need. So back to CVS. I apologize for my voice, I'm still sick, but hopefully by tomorrow I will be feeling better. So Starling curves. So Starling curve is basically tells you something like this. Imagine that you have a rubber band, and this rubber band, you put it between your fingers. The more you stretch it, the more quick it comes back. Yes? So stretch it more, it comes back faster. Stretch it more, it comes back faster. So let's say I stretch it just a little bit. It will come back with the power of 1 Newton, for example. If I stretch it more, it will come back with the power of 2 Newton. If I stretch it even more, it will come back with the power of 3 Newton, and like that. The more you stretch it, the strongest it gets back. So the heart is like a rubber band. If you put more blood in it, it will take, but then it will push back. Yeah, so more blood, push back. Hope you get like the concept of this idea. So do we call that the Starling curves? So let's see. Here we have stroke volume and ventricular and diastolic volume, so which is the same as the preload basically. So you can see the normal. If someone exercise, what will happen to the contractility of his heart? It will increase. So if someone contractility will increase, in exercise, contractility increase, so you shift to the left. Yes? But what happens during exercise to the heart rate, guys? Tell me. Heart rate exercise. Okay, it increases. If the heart rate increases during exercise, what will happen to the preload? Yes, it will decrease because there is no time to fill the heart. So, okay, someone has normal contractility. Now he has heart failure. What will happen to the contractility? Yes, the contractility will go down. So if you cannot contract the heart, you cannot push the blood out of it. If you cannot push the blood out of it, the preload will go up or down. Increase the preload. So yeah, it will shift to the right, yes? And if we say someone has heart failure, and now you gave him the digoxin, his contractility goes up. The digoxin increases the contractility, so the contractility goes up. And if the contractility goes up, what will happen to the preload? Decreases, exactly, shift to the left. Awesome job, guys. You are masters. You know what you are speaking about. This is awesome. Force of contraction is proportional to the end diastolic length of the cardiac muscle fiber, the preload, which means basically what I just told you. The heart is like a rubber band. The more you stretch it, the strongest it comes back. Put more preload, get more contraction, okay? So increased contractility can be with catecholamines and positive anatropes. We spoke about how catecholamines increase the contractility with the relation of the phospholambine and the beta-1 receptors, the protein kinase A, and all of the cyclic AMB, adenylate cyclase, and all of that process. And now I'm telling all of this stuff and it makes sense for you. And it's awesome. And exactly the beta 1 receptor. And also with the digoxin and how it inhibits the channel and increases the contractility due to the increased calcium inside of the cell. On the other hand, the decrease in the contractility with loss of function of the myocardium can be in case of MI. Well, does infarcted tissue contract? No, it does not. It loses its function. Remember, one of the stuff of irreversible injury, one of the signs of irreversible injury is loss of function. So the tissue here loses its function during MI, so it will have less contractility. So if, it has less contractility. Also, beta blockers acutely will lead to decrease in the contractility. The same with the non-dihydropyridine calcium channel blocker and the dilated cardiomyopathy. One question for you guys. If I have someone who has asthma and I want to give him beta blocker for his heart failure, for example, or for his increased blood pressure, should I give him beta blocker or calcium channel blocker? And if you say one, say why. Calcium channel blocker, why? What's wrong if I give a beta blocker to an asthma patient? Yes, it will lead to bronchoconstriction, and if it will affect the, it will lead to exacerbation of his asthma, basically. Good job. Okay, guys, so here is an important question. If someone has heart failure, why would I give him beta blocker that will decrease his contractility of his heart? That does not sound smart. Why I do that? Exactly. I want to decrease the myocardial work, decrease oxygen demand. When I decrease the oxygen demand and the oxygen consumption, your heart start beating in a better way, correct? Good. I am happy that you get it, guys. Okay. So these two pages were difficult. All of the physiology of the heart it is, so just bear with me. So after we finish this page, and hopefully tomorrow we'll do this page, everything else is just like much easier, seriously much easier. So, okay, this page. Okay, this will be last page in cardiology today because this will take a lot of time, the other page, and the rest of the time I will be explaining you something from pathology. So resistance and the pressure and the flow. Okay, so it goes something like this. There is this Ohm's law. I hope you guys know what Ohm's law. It's something in electricity in physics, basically, and it's something about the resistance and the flow and all of this stuff and the cross-sectional area of the wire. That's the Ohm's law. That's for electricians, not for us. But why they give you this? Because it's the same law they got the volumetric flow rate from. It's the same idea. So what does it mean? You don't have to memorize this formula. You don't have to memorize it for the test. I mean these ones. They are not needed from you. But you have to understand what they mean. They mean, look, the volumetric flow rate is equal to the flow velocity multiplied by the cross-sectional area. Guys, you already know it, but you forgot it. So let me show you what that means. So it means if I take Q equals to the flow velocity multiplied by the cross-sectional area. If this is the volumetric, which means how much volume is going through, okay guys? It's not the speed. The speed is different than the volume. If I increase the cross-sectional area, obviously there will be more amount of blood going through it. But the speed of it will be actually low. How come? Look here. If I move this down here, it will be Q divided by A. Yeah? And it will be equal to V. So the flow velocity is inversely related with the cross-sectional area. The lower the cross-sectional area, the fastest the flow. It doesn't mean the amount is bigger. It just means it's faster. And that's important to know. So it's like the water hose I told you about. If you make it smaller, the velocity goes faster. It does not make you pass more of it. You know, you don't. You pass less of it. Because if this goes down, this goes down. You have less water going through, but you have it much faster going. So yeah, that's the water hose concept. Okay, back here. Now this is a formula you sadly have to know. It says the driving pressure is divided by the volumetric flow rate. That's not the one you have to know. The next one you have to know. This one, which is 8. This is a constant you don't have to know. Multiplied by the viscosity, multiplied by the length, divided by radius 4. How can they even ask me about something like this? Well, they can. I will show you how. Guys, someone who has polycythemia vera, what will happen to his viscosity of his blood? Exactly. So the viscosity with someone with polycythemia, he will have thicker blood, and thus he will have increased hematocrit and thicker blood. Yes. So what will happen to the resistance? If we increase viscosity here, the resistance goes up, yeah? Good. Okay, guys, now the more interesting question. If you decrease the radius, what will happen to the resistance? Excellent, it will increase. Now it gets tricky. If the radius, let's say, decreased 2 times, and the viscosity increased 2 times, and they do this type of question. Again, the radius decreased 2 times. The viscosity decreased 2 times. What will happen to the resistance? Guys, let me tell you why it's wrong. So if you say that viscosity is 8, okay? And if you decrease it 2 times, it will become what? 8 will become 4, will become 2. So it will become 2. But if you go down here, the radius, let's say it become 8, so it again becomes 2. But guys, this is to the time 4, and this is just multiplied by 8. So this is just multiplied by 8, multiplied by 1 point something. And this one is to the time 4. So actually, what happens to the radius down here will be what? This guy will be decreased significantly compared to this guy, so the resistance will be up. Again, guys, did you, yeah, exactly. So the radius is the main one affected, not the viscosity. You need to be careful to this to the power 4. They can play it with you with so many different ways to basically ask you which one is the most important. Is it the radius or the viscosity? Which one is the most important, the radius or the viscosity? Controlling the resistance of the vessel. The radius, exactly. The viscosity is important, but not as much. For the length here, it's not important at all, because well, it's kind of really difficult to check the length of a vessel. So, and it does not change like in a way that is clinically relevant, but these two do. Okay, guys, someone who has multiple myeloma, which one will be changed, viscosity or the radius? And how it will be increased? Multiple myeloma. Viscosity increased, correct. What about pancreatic cancer? Yes, IgM. Okay, good. What about pancreatic cancer? Viscosity or radius will be increased? Pancreatic cancer can lead to hypercoagulable state, and all of your cells inside of your body will be with high viscosity. Good. What about renal cell carcinoma? It can lead to polycythemia vera, so it can lead to increased viscosity as well. Okay, guys, so the next one, excellent. So the next one is kind of interesting. They ask you how to calculate the resistance in vessels in series versus in parallel. What does that mean? If two vessels are connected to each other in parallel, in series like it's like one after the other. If I want to give you an example of this, it's like, you know, guys, we have this, the efferent arteriole, then we have the glomerulus, which actually one vessel, it does not divide, it's just one vessel, but it loops around itself so many times. And then we have, I apologize, it's A here, afferent arteriole, glomerulus, and efferent arteriole. Okay, so these are in series, yeah, because they go after each other, and you can just calculate the resistance of the afferent arteriole plus the resistance of the glomerulus plus the resistance of the efferent arteriole, and you get the answer. But if the question was about multiple organs connected together, let's say I tell you that calculate for me, and I hope you have pen and paper to calculate. Can you calculate for me the total peripheral resistance of the heart, liver, kidney? If I tell you that the heart, it will be, well, just for simplicity's sake, I will make them 1 on, the heart resistance will be 2, and the liver resistance will be 4, and the kidney resistance will be 4. Can someone calculate for me the total resistance? Let's see. Someone wrote 10, but these organs are connected not by series. You cannot just add them to each other. You have to do something like this. So it's 1 divided by 2 plus 1 divided by 4 plus 1 divided by 4, because they are connected in parallel, not in series. And then you do like this, just mathematics, guys. So multiply by 2, multiply by 2. So 2 plus 1 divided by 4, and that is equal to the RT. Yeah, don't forget the 1 here, guys. Okay, there is 1 here. So that all is equal to 1. Excellent, a lot of people got it actually. Okay, so 1 is equal to the RT. Yeah, makes sense? Good. By the way, if it becomes any number different than 1 here, be careful, you have to get rid of this one. Okay, so you will actually have to jump everything to the other side. Okay, so let's take a look here. So in series, we just plus them to each other. In parallel, we have to do this weird formula that requires you to put like 1 divided by the resistance of that one organ. I will tell you a constellation of organs and you tell me series or parallel. If I tell you about the gallbladder and the stomach and the colon, this is series or parallel? Parallel, good. What about if I give you the portal vein and the hepatic vein? Good. If I give you the aorta and the common iliac? Series, good. One vessel to one vessel. If I give you the brain and the heart? Parallel. Excellent job, guys. Good. So now we go back to this. Okay, guys. So what they write for us here. Capillary have the highest total cross-sectional area. Do not be tricked with this. It's a cross-sectional area, not pressure. And the lowest flow velocity. You are like, wait. You are wrong. The capillaries are the thinnest of the thinnest of the thinnest. I need a microscope to look inside of them. They don't have the highest total. They don't have the highest cross-sectional area. Yes, by 1, because if you put your aorta here, it's this big. Okay, it's really big. But if you take a capillary, maybe it's this big. But how many aorta do you have? 1. How many capillaries do you have? Millions. So actually it's the total cross-sectional area. So all of these millions next to each other, they will make much larger space than the aorta. Okay, so the total cross-sectional area is much higher. But the velocity, well, since it's much wider overall, so if the velocity will be in one vessel, let's say 2 meters per second, if you divide it into two vessels, it will become 1 meter each. Then if you divide it again, it will become half a meter each. Then a quarter of meter each, until you reach the capillary and it becomes so slow. Well, why it is super important to have really slow circulation inside of your capillaries, guys? Because, yes, for absorption. So you will have more gas exchange, better gas exchange, and you will have nutritional exchange. Because if it goes too fast, it will not have any time to pick up anything. It will just be going. So, okay, good. So pressure gradient drives the flow from the high pressure to the low pressure. This is just self-explanatory. So arterioles account for the most of the total peripheral resistance. Remember the thing I was annoying you about the whole day? Here it is. Arterioles are the main thing. And what thing inside of the arterioles actually control it? Total peripheral resistance, systemic vascular resistance, sphincter, precapillary sphincter. Good. Veins provide the most of the blood storage capacity. A lot of students mix that up. Okay, guys. So if we speak about the size of the arteries, what is more tight, arteries or veins? Yes, arteries are much more tight because their walls are thicker. Yeah. And if the wall is much more thick, it will be more difficult to pass blood through. Don't you agree? But the veins, on the other hand, have much more capacity to get the blood. Well, that's why we have almost 2/3 of our blood circulation actually located where? Inside of our veins, not artery. That's why when we have pooling of the blood, when we spoke about it, and the preload, they were mediated not by the arteries, they were mediated by the veins. So that's important as well. Okay, let's go back here. Okay, so they're right. Veins provide the most of the blood capacity and storage. Good. So we have viscosity depends mostly on the hematocrit. Remember, polycythemia vera increase the what? The viscosity. Viscosity increase in the hyperproteinemic state like multiple myeloma and in cases of polycythemia. Viscosity decreases in case of anemia. So if the viscosity decrease, what will happen to the resistance? Good, it will decrease. Good, good, good. Okay. I will not. Okay, let's take the break now because this is like an important concept that you cannot understand when you are having a headache from my voice. So anyway, let me show you how much time do we have left. Okay, so guys, come back in 10 minutes. Okay, so it will be 8.8. See you. Okay, guys, so here we go. Okay, let me check. Yes, you can hear me. That's good. Okay, now we are going to speak about the cardiac and the vascular function curves. So in the cardiovascular system, there is cardio and there is vascular system. So we are speaking about the cardiac, the heart, and the vessels. So the heart gets a curve, the vessels gets a curve, but these curves are associated with each other, so we put them in the same graph. We call them the cardiac function curve and the vascular function curve. So two curves, not one. Take a look here. So can you see this red curve? This is the cardiac function curve. And I want you to know that the cardiac function curve is mediated by the contractility of the heart, which is also called anatropy. So the word anotropy is, when I tell you anotropy, you will tell me this is the same as saying the contractility. Okay, guys? Contractility is anotropy. Anotropy is contractility. Okay? So anotropy, when it's increased, there is high contractility. When it's decreased, the anotropy, there is decreased contractility. When there is high anotropy, which is in contractility, what will happen to the cardiac output? It will go high. When there is decrease in the contractility, which is the same as the anotropy, the patient will have what? Decreased cardiac output. So this is the cardiac function curve. If we say, let's see if you understand what I mean. So if I put you here, guys, and I ask you the following. In this picture, what is if I give someone beta blocker, will the graph be shifted up or down? The cardiac function curve. Up, correct. If I give this person a beta 2 agonist, sorry. Well, if I do give him a beta 2 agonist, there will be vasodilatation. There will be vasodilatation. Your blood pressure will go down, but your heart rate will go up. It reflects tachycardia with higher contractility, so it will move up. That's a like two-step equation. Anyway, next one. Can you tell me, please, someone with thyrotoxicosis, which is increased thyroid hormone? Up, down? Up, good. So this is the cardiac function curve. So that's the cardio thing from the cardiovascular system. Now let's speak about the vascular function curve, okay? So the vascular function curve goes something like this. It's the ability of your venous return. When I say venous return, you start thinking about what? The preload, okay, guys? And let's take a look here. So the preload, it's something like this. So the vascular function curve, if you move to this side, there is more fluid in your heart. If you go to this side, there is less fluid in your heart. Less fluid, high fluid, where exactly? In your right atrium, right atrial pressure, okay? So if we say someone, again, let's put you up there, guys, and you tell me, someone has heart failure, what will happen to his preload? So if it increases, it will shift to the right or shift to the left? The amount of the blood, the amount of the preload, heart failure, again, guys, look, if someone has heart failure, okay, he cannot pump the blood forward, so it will go backward, correct? So the preload inside of the left atrium will go up, yes? The amount of the fluid inside of the left atrium will go up. If I draw this for you, this is the left atrium, this is the left ventricle, this is the aorta. The patient has heart failure. This pump is not pumping anymore. So what will happen? The blood will be accumulating inside of the left atrium. That will increase the amount of the blood inside of the left atrium. If you increase the amount of the blood inside of the left atrium, the right atrium pressure will go up. If it goes up, your right atrial pressure will go to the right. Yes, guys? Okay, let me give you another example. If someone takes catecholamines, exercises, or does something like this, and he has tachycardia, basically, if you are in tachycardia, first of all, the cardiac function curve will go up or down? Contractility. Up, correct. In the same condition, increase catecholamines and exercise, you are in state of tachycardia, so the amount, okay, good, decrease the preload, so it will shift to the left or to the right? Okay, guys, good, left, it will be to the left. So let's take a look. We have the following two curves, cardiac function curve, and we have the vascular function curve. they write intersection of the curves, which is this point, is the operating point of the heart, where the venous return and the cardiac output will be equal, as the circulatory system is a closed system. What does that mean? Since your heart chamber, since your cardiovascular system basically gives to each other, it's a closed system. It does not like contact to anything from the outside. So the cardiac function curve and the vascular function curve must transact with each other because it's a closed system. So in the diagram A, as you can see here, it is about the anatropy, which is the same as telling you the contractility. Changes in contractility will lead to alteration of the stroke volume, which is the amount of the blood pushed outside of the heart per one push, like one beat. There will be alteration of the cardiac output and the VR and there will be an altered cardiac output and venous return and the right atrial pressure. So what exactly will change in these? So the cardiac output, if you take example number 1, catecholamines or digoxin or exercise, all of these increase your what? They increase your anatropy, yes? So your contractility will be much higher. Good. So what about the other one? What will happen to the vascular function curve? Well, in reality, if you use your, if you have a lot of catecholamines, digoxin, and exercise, you have tachycardia, okay? And if you are tachycardic, you're contracting your heart so much, what will happen to your right atrial pressure? Your right atrial pressure, you are getting all of the blood outside of your heart, so it will go down. So when it goes down, the right atrial pressure, it will be somewhere to the left, so it will be here, okay guys? While on the other hand, if we speak about the heart failure with reduced ejection fraction, so heart failure with reduced ejection fraction, is it systolic or diastolic heart failure, guys? Reduced ejection fraction. Systolic, excellent. So systolic heart failure, it's when you have decreased ejection fraction. What is the normal ejection fraction? 55 or 60, yeah, with this range. Good. So also when you, so in case of heart failure with reduced ejection fraction, your contractility goes down. The if that is the case, more blood will pool inside of your right atrium, so the right atrial pressure goes up, and that leads to shift to the right on the vascular function curve. And in the cardiac function curve, there will be shift downward, okay? And the other cause, narcotic overdose. Someone does narcotics, not the good ones. Like something, he used some of these depressants, like opioid or something. Not, by the way, be careful. Narcotics not always inhibitory, because we have the stimulant like cocaine. This is totally different. But if it was an opioid, it will decrease your anatropy and your vascular function curve will go to the right, and that will increase basically the amount of the blood inside of your right atrium. That increases the right atrium pressure. Okay. So. We also have here, they mention sympathetic inhibition. So when there is sympathetic inhibition, can you guys give me an example about something that can lead to sympathetic inhibition? Anything you can think about. What can inhibit your sympathetic nervous system? You can think about, well, yeah, anesthesia. What about medication? Give me a medication. One medication I kept annoying you with it, guys. It leads to, for example, beta blockers, guys. Beta blockers, yeah? They decrease sympathetic activity on the end organ. Well, the catecholamines is not functioning. That's the main idea. So if that is the case, the anatropy will go down, as you can see here, and the vascular function curve will go to the right. Hope it makes sense. Just a matter of knowing what everything is located on the graph. The second graph is about venous return mainly. So let's see what speaks about. So we have changes in the circulating volume will lead to changes on the graph. Will lead to altered right atrial pressure, altered stroke volume, and change in the cardiac output. So let's try to understand this together. So the first thing, if you have a fluid infusion, someone got an infusion of normal saline, okay? If you get a lot of normal saline, first of all, let's take this one, which is the vascular function curve, okay? Your vascular function curve, which as you can see is controlled by the right atrial pressure, will change. More fluid in the system, more right atrial pressure there will be. So there will be a kind of shift to the right, yes? So the amount of the volume will be higher, there will be shift to the right. So what will happen to the cardiac output in this case? If you have more volume inside of your heart, what will happen to the cardiac output? Good, increase. So sympathetic activity, when it's increased, also that increases the amount of the volume and the venous tone, which lead to the increase to the preload, basically. And can you tell me, please, what will and the other one here is acute hemorrhage. If someone is bleeding so much, what will happen to his right atrial pressure? Increase, decrease? Bleeding. He's bleeding so much. Decrease, yes, because where is the blood will come from? Of course it will be decreased because he's bleeding. Okay, so yeah, hypovolemia, good. In cases also of spinal anesthesia, the idea here that the venous tone increase or decrease with the spinal anesthesia. Yes, it decreases. That allows it to accommodate for more fluid, and thus it fakely decreases your vascular function curve. I hope it makes sense, these two concepts. The next one is the total peripheral resistance. So the total peripheral resistance is due to the change in the total peripheral resistance leading to alteration of the cardiac output. So and change in the right atrial pressure is unpredictable, so screw that, you'd have to know. But what you have to know, guys, if there is vasodilatation in the vessels, what will happen to the cardiac output? Well, what will happen to the contractility of the heart? If there is dilatation of the vessel, your heart wanna compensate for the hypoperfusion of the organs, so it will start pumping faster. But let's say that you have vasoconstriction, massive vasoconstriction, what will happen to your heart rate? It will be decreased. So that's the last curve. It says something like this. It's about the total peripheral resistance, which is mainly controlled by which vessel inside of our body? Arterioles, excellent. So the total peripheral resistance can be either increased or decreased. So, and we can see it here. So total peripheral resistance, if you decrease it, how can I decrease it? Well, for example, a patient has an AV shunt or he does exercise. What is an AV shunt? Guys, do you know these people on dialysis who have this AV shunt? Let me show you. Like, for example, it can be like an AVM, atriovenous malformation, or it can be iatrogenic, which means like we do it, to do dialysis from. You know, it's quite painful for the patient of dialysis to keep getting this injection every single week or 3 times a week. So we make them a fake one, like this, which connects an artery by a vein. It's kind of bad, but awesome because vein-free, basically, less risk of a thrombosis. But at the same time, it leads to a problem because there will be passage from the circulation, the arterial circulation, to the venous circulation. So you will not go through the what? You will not be going through the arterioles. If you do not go through the arterioles, the blood pressure will drop significantly, yeah? Yes, the fistula. And if that is the case, you can take a look here. In case of AV shunt, the total peripheral resistance drops because you bypass basically the arterioles, you don't go through them. So the total peripheral resistance is dropping. Yeah, so the venous return, the amount of the blood going back to the heart will increase. If you imagine that we have like an artery and a vein, and the blood is escaping from the artery to the vein, okay, and it's not going to the arterioles, two things will happen. The pressure will be dropping because arterioles are the one controlling it, and more blood will be going back to the heart. That increases the venous return. That's why the graph here is shifted upward, okay? In the same time, if you stretch the heart more, the Starling mechanism will work. Stretch more, contract more. So the anatropy will go up. And the opposite is the opposite. If you use vasopressors, for example, can someone give me an example of vasopressor? Good one. But no, seriously, vasopressors. Well, norepinephrine, no, not beta blocker, norepinephrine, anything that leads to vasoconstriction, basically, guys. Well, beta blocker can be, but it's not that. Beta blocker on the beta 2 lead to vasoconstriction. Yes, alpha agonist like phenylephrine or epinephrine. Okay. So yeah, vasopressors lead to vasoconstriction, basically. If that is the case, the total peripheral resistance will increase. If it increases, the venous return will decrease. If it decreases, the graph will go down if on the basically the vascular function curve. But if you speak about the cardiac output, when the cardiac output will also will decrease. Why? Because when they see so much afterload against them, they will be like, screw that, I'm not getting any blood outside of here, the afterload is so high, so the cardiac output goes down. Okay, so that's how vasopressors lead to, first of all, increase in the total peripheral resistance, which lead to the venous return being less. That's why the vascular function curve is dropped. And also, when the total peripheral resistance is high, the afterload is high, which tells the heart and the cardiac output to decrease. Okay, so let's go down. Changes often occurs in tandem and may be reinforcing. For example, exercise increases the anatropy and decreases the total peripheral resistance to maximizes the cardiac output. In case of exercise, you want your cardiac output to be super high, so you increase the contractility of the heart and you decrease your total peripheral resistance, so you get 2 for 1 here. Or it can be compensatory, which means the heart failure decrease the anatropy. So in case of heart failure, the anatropy of our heart is much less, and the fluid retention. In case of heart failure, the anatropy has dropped. So the amount of the preload will be higher. Why? Because there is fluid retention and basically back flow of the blood, which will lead to increased preload to maintain the cardiac output. Also, in case of heart failure, the reason we have the pulmonary edema is basically due to the increased back flow of the blood. Okay, guys, now democracy will work again. Should we do question or should we go do pathology? Wow, okay, chill, guys. So, okay, let's see. Well, first the question. We have a 23-year-old woman. Today I brought you from UWorld according to our election. So 23-year-old woman is brought to the emergency department with chest wound. She was having a chest wound. So she was in her house during severe thunderstorm when a large tree branch fell through the window. The window was shattered and a large fragment of the wood and glass struck the patient. Okay, so she was hit by a glass. She did not lose consciousness, but her family found her bleeding profusely and rushed her to the hospital. Her blood pressure is 80/50, which is decreased. Anything that is under 90/60 is considered shock. And the pulse was 130. Yes, she's in hypovulemic shock. The patient appears to be in severe distress. Physical examination shows a deeply penetrating wound in the fourth intercostal space along the left sternal border. Smaller lacerations are noted across the forearm and the face. Which of the following is the most likely injured in this patient? Is it the inferior vena cava? Is it the left atrium? Is it the left ventricle? Is it the pulmonary trunk? Or is it the right atrium? What do you think, guys? So basically, let's see. Okay, so the area that was injured in here is basically the anterior most chamber of the heart, which is... Excellent job, everybody. It's the right ventricle. You are totally correct. And what is the posterior most chamber of the heart? Can someone tell me? Left atrium. Good. And if that gets enlarged, the patient will have which problem? Dysphagia and hoarseness. So the dysphagia due to the esophagus and the hoarseness is due to affection of which nerve? Recurrent laryngeal. Awesome. Good job, guys. So, okay. So, yeah, the correct answer was the right ventricle. And yes. So, see? The stab wounds. Just be careful. If they tell you it's at the apex, it will be the left ventricle. But otherwise, it's the right ventricle. Okay, guys. So, let's see the next question. By the way, guys, remind me after the class, those who do not have online New Word, contact me and we'll manage something. So the next question. A 54-year-old man comes to the office due to the episode of burning substernal chest pain. And his pain increases with activity and improves with rest. The patient has a history of hypertension and hyperlipidemia. He has smoked a pack of cigarettes daily for the past 30 years. His blood pressure is high, and he has an S4 of his heart. Okay, S4. So a lung and an abdominal examination are unremarkable, all good. ECG at the rest shows left ventricular hypertrophy. Okay. A myocardial perfusion scan reveals inducible ischemia of the inferior surface of the heart. Which of the following coronary artery is most likely occluded? They are asking us which coronary artery supplies the inferior surface of the heart. Let me remind you about one thing. The heart is a little bit twisted, and your right ventricle is the one located like in the inferior side. So let's see. So people are writing right coronary artery. D is right coronary artery. Some people writing posterior descent. Is that an option? Left anterior. No, it's not an option. Leads one. Oh, yes, lead one. Lead. In case of inferior MI, it will be lead 2, 3, and AVF. But the correct answer here, the myocardial infarction, is in the D, right coronary artery, which supplies the inferior surface of the heart, which is basically the right ventricle. Let me show you. See the right coronary artery, guys? The heart is actually twisted like this. If you take this picture, you put it here. Yeah. I don't know how to do it. Basically, you have to flip it, guys. Oh, yeah. Just like this. But anyway, so this is the inferior surface of the heart, which is the right ventricle. Just know it. Okay, so the right ventricle is the inferior most surface of the heart. Thus, it supplied the right ventricle by what? The right coronary artery. Okay, so the next, oh, by the way, see this, guys? This patient is right dominant. If we connect these two vessels, he becomes codominant, but if the BDA comes from, which is the posterior descending, comes from the left, from both of them, we say it's a codominant. Okay, now I brought you a good X-ray. I hope you will know it. Let's see. A 62-year-old man comes to the emergency department due to fever, productive cough, and dyspnea for the past several days. His symptoms are becoming progressively worse. The patient has an underlying mild COPD and has smoked tobacco cigarettes daily for the last 40 years. His temperature is high, his pulse is high, his respiration are fast. Auscultation of the right lung reveal bronchial breath sounds and crackles. Laboratory evaluation show leukocytosis. They show you the following X-ray. And they show you this area that you can see a lot of stuff here. Yes, guys, there's some form of consolidation here. And they tell you a mediastinal contour obscured by lung consolidation on the chest X-ray was seen, which is this thing. Like, this is consolidation of the lung, and it's pushing the heart from its right margin. And they tell you which of the right margin of the heart is made from which of the following. Guys, I did not explain you this one, so even if you get it incorrect, it's totally okay, since I did not explain it for you, and we'll speak about it now. So, but you can try if you want. Okay, so they write one person wrote D, one person wrote B. And the answer is actually D. So this is the right atrium. I want you guys to save this picture. I used to have it as the background of my phone, actually. This one. You have to know that the superior vena cava is here, right atrium is here, inferior vena cava is here. You have to know this is the aortic knob, and if it enlarges, that means something. You have to know that the left atrium is here. If the left atrium is here and it enlarges, what will happen to the aortic knob? Correct, it will go up. This is your left ventricle, right atrium. Left ventricle, right atrium. So yeah, for those who don't have a screenshot of it, here you go. And I will be sending the whole file after the class. Okay. The next one, question 5. Okay. It says, 23-year-old, a previously healthy man is brought to the emergency department after a stab wound. His friends report that they were walking down the street in the midnight. Minding our own business when a guy jumped out in front of us from behind the dumpster and stabbed him in his chest. They were able to disarm the man after this single attack. So he stabbed the man in his chest, then he ran away in the alley. So the patient is unconscious but in distress. Physical examination shows a lateral directed anterior, so laterally directed, this is important, laterally directed anterior chest wall stab wound at the fifth intercostal space along the left midclavicular line. Which of the following structure has been injured? Guys, before you answer, I want you to know one thing. The apex of the heart location. I want you to know that if you take the midclavicular line, it's here, okay? And the apex of the heart is located 2.5 centimeter to the right of the midclavicular line. This man was stabbed where? Exactly at the midclavicular line, and it was pointing laterally. Okay, so take a look and decide. Write in the chat, guys. Yes, D is the left lung. That's correct. So yeah, you have to know where is the apex located, and according to that you decide, and you were correct. Basically, it's 2.5 centimeter to the right of the midclavicular line. So if he was stabbed at the midclavicular line going laterally, it will be in the lung. Correct. And if you hit the lung, you are at high risk of getting pneumothorax. Yeah, you see, he was stabbed in his lung. They really wanted you to know about the apex. Okay, more X-rays. So, this is the last one. A 65-year-old man with a history of coronary artery disease comes to the physician complaining of a progressive exertional shortness of breath and fatigue, and lower extremity swelling. His medical history is significant for an MI 5 years ago. Electronic pacemaker was implanted 2 years ago. And they show you the following chest X-ray, and it's highlighted by an arrow. So there is something here, some structure here, like normal structure of the heart. And here there is like something, and here we know what is here. It's like the ventricle. There is something here. And they ask you, what is that? So what is that? Is it your anterior interventricular sulcus, or is it the atrioventricular groove, or is it the pulmonary artery? Is it the right atrium, or is it the right ventricle? Remember, they are just speaking about the line. Come on, tell me, put answers. More answers, please. So we have, wow, that's impressive. Okay, so we have a lot of people. No, it's not the right ventricle. It's actually B. The answer is B. It's the atrioventricular groove. So let me show you what this is. Just a second. It's the atrioventricular. Oh, wait a second. No. Yeah, atrioventricular groove. I was correct. So let me show you what that is. I just brought you this question because they were not in first aid, and I really wanted to find something that is not in first aid to ask it for you guys. So see this area. This is what you are seeing in the X-ray, and they are asking you about the atrial groove. Okay, the atrial groove is called what? The atrioventricular groove. It separates the right atrium from the right ventricle. Okay, so yeah, that's it. Okay guys, now some brainstorming. I will be asking you stuff all over the book, some from here, some from there, stuff that we explained before, and you have to answer everything. Can someone tell me where is the pericardial cavity located? Is it 1, between the fibrous pericardium and the parietal pericardium? 2, between the parietal layer and the visceral layer of the serous pericardium? Pericardial cavity. What is the location of pericardial cavity? The question is. Remember please that the pericardium has like 3 layers. It has this an outermost layer, okay? And then it has 2 serous layers. The T serous layer between them, one is parietal, we call it, one we call it visceral. Between them is the cavity, okay? So you can see even in first aid it's written here. The cavity lays between the parietal and the visceral layers, okay? The fibrinous layer is attached, it connects with the parietal layer of the serous pericardium. Okay, in case of Ortner syndrome, what is Ortner syndrome? Ortner syndrome. Yes, it's affecting of the left recurrent laryngeal nerve. And can someone tell me the left recurrent laryngeal nerve goes around what? What structure it just goes around it? Exactly, the aorta. What about the right one? It goes around what? The right one. Right recurrent laryngeal artery. The right recurrent laryngeal nerve. Come on, I'm waiting. Right recurrent laryngeal nerve. No answer is correct yet. Brachiocephalic artery, not the brachial artery. Brachial artery is in your arm. So it will be the brachiocephalic, which from it gets out what? The right subclavian. And what is the other vessel? The common carotid. Okay, guys, so that's it for today. We will be contacting on the group to decide when we are going to have our next class. Remember, in general, we have 3 to 5 classes per week. I think for the initial few weeks, actually, maybe the initial month, I would like to have as much classes as possible every single week. So we'll finish as much material as possible, because the harder we work now, the easier it becomes in the future. You just have to build your foundation now, and the moment you build your foundation in these topics, it becomes comfortable. Like, yes, CVS and pathology might be a little bit difficult for you. Next system, it will be moderate, but by the time it becomes easier and easier, the moment you finish, it becomes a piece of cake. So, okay, guys, I will see you later, and good luck for everybody.